Muy bien, pues en breve tendremos.
Okay, so briefly we will have the next talk by Dr. Sejona John, who will be with her in just a short notice. In the meantime, we're going to have a few comments regarding how everything is going with the International Forum, and Dr. Rodriguez would like to chime in as to this particular topic. Well, I want to take advantage of these few minutes that were given to me to remind you that this is our 25th iteration of the course. It has been the product of a joint effort for the entirety of a team who have constantly worked in making sure that it actually happens. We haven't left it on the wayside regardless of a pandemic. And as things are happening, regardless of how the pandemic is occurring, and there's a lot of contagion as of late, we have seen that the academic activities have finally been renewed, and we know the academia is essential, and this is something that happens in a continuous manner. So the next year, we will definitely see each other in person in Mexico City, as we've done for the past 25 years. These past 3 years, we've done so virtually, but it has been a push from the team this time around with Dr. Gutierrez and Dr. Baltasar Torres to make sure that this is kept as a continuous event. So we hope to see you next year. We want to thank our remote professors and teachers, whom we'll be very glad to see the next years. We will, of course, we'll say hello to each other with whichever restriction we would need to follow, but make no mistake that we will definitely see each other next year. And I believe we're ready for the next talk. And I want to thank Dr. Zendaya John for making sure that she's part of this momentous occasion and effort. Thank you, Doctor, for your comments. And now we're going to go to the next talk of the day. We will have against Dr. Sejona John with the advancements in updates in the management of intracerebral hemorrhage.
Thank you so much. My goal with this talk today really is to review the updated guidelines that have just been published by the American Heart Association and the American Stroke Association. These are the 2022 guidelines, and how that impacts our management of patients presenting with intracerebral hemorrhage. So I think all of us know that the primary intracerebral hemorrhage results from direct bleeding into the brain, and it accounts for 10 to 15% of all strokes. Unfortunately, it carries a high risk of death or long-term disability, especially when compared to other forms of strokes. And because of that, we consider this an emergency, because are there potential treatment options or injury mitigation options that can prevent the risk of ongoing secondary brain injury? So initially, when the patient presents, the goal is to do a quick targeted assessment for potential early interventions. And that includes control of elevated blood pressure, correction of coagulopathy, determine if there is any surgical intervention that can be offered, and then consider specific treatments that are related to the underlying intracerebral hemorrhage cause. So this is a CT, which is the gold standard for determining hemorrhage, and is sensitive close to 100% as soon as this event occurs. And what you're looking at is different locations of an intracerebral hemorrhage, classically determined to be hypertensive locations, which is the basal ganglia, the thalamus, a lobar hemorrhage, cerebellar hemorrhage, as well as a brainstem. And in this particular instance, it is located in the pons. And some of the things that we have to do up front, and this becomes relevant as I go through the rest of my talk, is to calculate out the volume of the hemorrhage. And the methodology that we use is the ABC by 2. And this depends on the number of slices the hemorrhage is located in, because when this was originally created, the CT thickness used to be close to a centimeter, and now it's closer to 4 millimeters. So learning how to correctly measure the size of the hemorrhage becomes important. We also do calculate out the ICH score, and this is a Joint Commission requirement that we calculate the score because there's an association between the score and 30-day mortality. And this, obviously, the higher the score, the higher the risk of mortality. And if you have an ICH score of 4, it's a pretty close to 97% mortality rate within 30 days. So the first thing that we are concerned about is hematoma expansion, because it is common and it is associated with worse outcomes. Generally speaking, it tends to occur early. It is usually within the first few hours of onset, and this really depends on what time the patient presents to an emergency room. Because if they present at 6 hours, you may not necessarily observe the hematoma expansion, but if they present early, within less than 3 hours, and if you were to do serial CT scans on them, you will notice that the hematoma expands, and this can continue up to 24 hours. We do know that coagulopathy increases the frequency and the extent of hematoma expansion. And however, it is important to note that even patients who do not have an underlying coagulopathy or are receiving antithrombotic medications can continue to have hematoma expansion. So there are several radiographic ways to assess if a hemorrhage is at risk for expansion. The first one that we're looking at is the blend sign, where you can see different layers or ages of blood, and the arrows are pointing to the hyperacute version area of the blood. And so this is a hematoma that's at risk for expansion. In the middle is the spot sign, and this was first identified when patients were getting CTAs to understand the etiology of intracerebral hemorrhage. And what you're looking at, what the arrow is pointing at, is contrast extravasation. And what that tells you is that this is an actively bleeding hematoma. And then you have this air fluid levels, so to speak, where the blood is layering, and you have an area of hypodensity above that. And this is generally seen in patients who are using some form of anticoagulant, and this, again, is telling you that this hemorrhage is at risk for continuing to expand. So the hematoma expansion is an independent predictor of neurological deterioration, mortality, and poor functional outcome. And the hematoma expansion within the 6 to 24 hours can range anywhere from 6 to 15%. You can also get delayed intraventricular hemorrhage, and it's reported in about 21% of patients who do not show intraventricular hemorrhage on their initial CT. So in patients who have a stable exam after they have presented and have a preserved level of consciousness, then the recommendation is to get follow-up CT scans at about 6 hours and for sure at 24 hours after the onset, in order to exclude hematoma expansion, as well as to make sure that they are not developing an intraventricular hemorrhage, and to document a final ICH score. So moving on from hematoma expansion to blood pressure control, because this is the million-dollar question, because majority of the patients who present with an intracerebral hemorrhage will have an elevated blood pressure. Now, is that as a result of the fact that the body is trying to perfuse the brain in the setting of elevated intracranial pressure, or is it because these people have baseline uncontrolled hypertension, and as a result, what you're looking at is a blood pressure that is elevated? I think it's perhaps a combination of the two. So then what do you do with these highly elevated blood pressures, and what numbers should you be lowering this to? So the two clinical trials that all of the evidence is at the present point in time based on is the INTERACT-2 and the ATTACK-2 trial. So the Interact-2 trial looked at rapidly lowering blood pressure in patients who presented with an intracerebral hemorrhage, and this had to be done, I believe, within 6 hours. And the goal was to lower it to less than 140 in the treatment group, and for the others, it was just being maintained less than 180 based on the previous American Heart Association guidelines. And the outcomes did not show any benefit to lowering the blood pressure acutely to less than 140. However, on the secondary outcomes, there were improvement in a broad range. Most notably, patients who survived that event stated that they had improvement with their abilities to do their usual activities as well as to manage their self-care. So while there was no significant effect of intensive blood pressure lowering on treatment on hematoma growth as well, there was some subjective improvement in outcomes for patients if they survived the ictal event. But it's noteworthy that nearly 75% of the patients that were enrolled in this trial had what is defined as mild to moderate-sized hemorrhage, which means that their hemorrhage was less than 20 ml. And also, only a third of the patients achieved the target blood pressure within 1 hour. Half of them achieved it only by 6 hours, so the goal of the trial was to get it lowered as quickly as possible. Now, talking about the ATTACK trial, also a similarly done trial where the blood pressure was either lowered to less than 140 or to the AHA standard of less than 180. And this study also looked at primary outcome as death or disability defined by the modified Rankin score. This trial was discontinued early as a result of the outcomes, and they concluded that treatment of participants with intracerebral hemorrhage to achieve a target systolic blood pressure of 110 to 139 did not result in a lower rate of death or disability than standard reduction to a target of 140 to 179. However, again, the primary endpoint, while it showed no benefit, and neither did it show a difference in hematoma expansion rate, what was notable is the fact that there were several safety events. And the percentage of patients that had a higher serious adverse event at 3 months was higher in the intensive group. Predominantly, it was renal adverse events. So when you look at the unadjusted relative risk of death or disability at 3 months, according to the subgroup interpretation, you can see that the trend was better for the standard treatment, which means that maintaining the blood pressure less than 180, patients tended to fare overarchingly better. So intensive reduction in blood pressure does not provide an incremental clinical benefit. However, the results cannot be generalized to patients with large hemorrhages, those that have an elevated intracranial pressure or a compromised cerebral perfusion pressure, because those patients were excluded from both of these trials. And you always run the risk of precipitating a global or regional cerebral hypoperfusion with intensive reduction of systolic blood pressure. So elevated blood pressure is extremely common, and the two trials were unable to prove benefit to aggressively lowering the blood pressure to less than 140. And in patients with the potential for elevated intracranial pressure, the goal should be to try to target a cerebral perfusion pressure greater than 60. That is easy to state because not every patient that presents with an intracerebral hemorrhage has any form of intracranial pressure monitoring that you can target the cerebral perfusion pressure. But if you do have an ICP monitor, then it makes sense to maintain the cerebral perfusion pressure greater than 60. So these are the 2015 guidelines that it was safe to lower the blood pressure to less than 140 as long as patients were similar to those enrolled in Interact-2. That means that if they had small hemorrhages. And if the blood pressure is greater than 220 at presentation, then you should consider aggressively reducing the blood pressure, and you should use continuous intravenous infusions with frequent BP monitoring, but note the fact that they don't say what you should lower the blood pressure to. So most of us in practice choose to do less than 160, and that has just been our practice for the last several years. So here's what the 2022 guidelines. So as you can see, there are many recommendations in here. But most notably, if the patient presents with an intracerebral hemorrhage with a systolic blood pressure greater than 150, then acutely lowering it to less than 130 can potentially be harmful. So any potential benefit of blood pressure lowering after an intracerebral hemorrhage might be enhanced by earlier reduction. So I think this is a statement that's particularly important, that you want to get to lowering the blood pressure as quickly as possible, because as more effectively that you do it and more sustained that blood pressure lowering is, then the patients tend to have a benefit as a result of that. If they have a mild to moderate hemorrhage, and the AHA 2022 guidelines defines this as a GCS score greater than 5, but they excluded massive intracerebral hemorrhages, then lowering it to less than 140 appears to be safe. So to rephrase that, if they have a small hemorrhage and the GCS is greater than 5, then it's probably okay to lower it to less than 140. And in moderate to severe intracerebral hemorrhage, and that they defined as a GCS less than 13, then early blood pressure lowering to reduce hematoma expansion did not reduce the rate of death or disability at 90 days. So if you have a large hemorrhage, then the goal of the blood pressure management is still up in the air. We agree that it has to be reduced, and it should be reduced as quickly as possible. Perhaps we can still stick with the goal of less than 160. Moving on to coagulopathy. So in any intracerebral hemorrhage, if the patient is on antithrombotic medications, then that is a life-threatening emergency, because for those patients, hematoma expansion is a given, and it carries an extremely high mortality and morbidity. So for every patient presenting with an intracerebral hemorrhage, urgent laboratory tests should include CBC, the platelet counts, INR, and PTT. And interventions to treat the coagulopathy should be based on history and laboratory values, and it should not be based on the size or location of the hemorrhage or their clinical scores, because those may not necessarily reflect the potential for deterioration that these patients have. And of course, anticoagulation should be discontinued immediately, irrespective of the cause that these patients are on anticoagulation for, and the anticoagulation should be rapidly reversed, and this improves survival. Earlier treatment is associated with a trend to better survival after you control for the severity of the bleed. That is based on the ICH score. And in a large observational multi-center study, earlier, that is less than 4 hours, reversal of VKA-related, which is the vitamin K-associated anticoagulant-related hemorrhage, to a goal of an INR less than 1.3, combined with blood pressure control, was associated with a significant reduction in hematoma expansion and lowering in-hospital mortality. So if you have a patient that's presenting with a vitamin K-associated intracerebral hemorrhage and the INR is greater than 4, 4-factor PCC or prothrombin complex concentrate is recommended in preference to fresh frozen plasma in order to achieve rapid correction of INR and to limit hematoma expansion. You should also simultaneously administer IV vitamin K in order to prevent a later increase in INR, because the effect of PCC and or FFP truly only lasts for about 24 hours. At that point, you want the vitamin K to kick in, because vitamin K production is inhibited in these patients, and you want to get the liver to start to produce the factors that are necessary to continue to maintain the INR where you need for it to be. And 4-factor PCC is superior to FFP at rapidly reversing anticoagulation to an INR of less than 1.2 within 3 hours of start of treatment, and that difference is 67% for PCC versus 9% for FFP. For direct oral anticoagulator-associated hemorrhage, again, you have two different kinds. You have the direct factor 10A inhibitors, and then you have dabigatran. So for the direct factor 10A inhibitors associated spontaneous intracerebral hemorrhage, andexanet alpha is the reversal of choice and is actually created for the reversal of factor 10A inhibitors, and it is reasonable to use andexanet assuming you carry it. And for dabigatran associated intracerebral hemorrhage, abrocitinib is also a direct reversal agent for dabigatran, and it is reasonable to reverse it assuming you carry abrocitinib. So what happens if you don't carry either of these agents, because they are both expensive? And while many centers in the United States do have the availability of these drugs, it's not prevalent. So your alternative is to use a 4-factor PCC or activated PCC in order to improve hemostasis. While it is unclear exactly how this works, it is beneficial and it does help prevent that hematoma expansion. And in addition, if the DOAC agent was taken within the previous few hours, you can consider activated charcoal in order to prevent absorption of the DOAC. With dabigatran, if ibracizumab is not available, you can use either activated PCC or 4-factor PCC to improve hemostasis. Alternatively, you can also consider renal replacement therapy because it does wash out dabigatran and reduces the concentration. Now, we're all familiar with how to reverse heparin and heparinoids. In case of unfractionated heparin associated intracerebral hemorrhage, IV protamine is reasonable to reverse the effect of heparin, and you want to give it to the patient as quickly as possible. With low molecular weight heparin, the IV protamine is only partially effective in reversing the effect of heparin. However, you really, unless you have, andexanet is also includes reversal of Lovenox, though I'm not sure how prevalent the use of andexanet is if you have a Lovenox-associated intracerebral hemorrhage. You can, however, use protamine, which will partially reverse the effect of heparin. And again, it is all about the timing of the administration of protamine. So this is the graph that's available. It's publicly available. The AHA guidelines are publicly available, and it walks you through exactly all of the things that I just spoke about, and is a quick and easy way to have in mind how to reverse anticoagulation. So with regards to other reversal agents in patients presenting with an intracerebral hemorrhage who have or maybe don't have a spot sign, because not everybody gets a CTA, so we're not always going to see a spot sign. We do know that the effectiveness of recombinant factor 7A to improve functional outcome is unclear. It hasn't actually proven to be beneficial. And the effectiveness of tranexamic acid to improve functional outcome is also not well established, even though there's quite a benefit to its use. With traumatic brain injury, we don't necessarily see the same benefit with patients presenting with a primary intracerebral hemorrhage. Now, with regards to antiplatelet-related hemorrhage, because majority of the patients are either on aspirin or they're on aspirin and Plavix, because many of them who have the risk factors for developing an intracerebral hemorrhage have the same risk factors for development of coronary artery disease. So then, what do? So patients who present with intracerebral hemorrhage who are on aspirin and require emergency neurosurgery, only on those patients is a platelet transfusion worth considering, because it does reduce postoperative bleeding and mortality. And this is based on the PATCH trial that was published a few years back, which clearly showed that for patients with intracerebral hemorrhage who presented while on aspirin or dual antiplatelets, platelets were actually, transfusion actually caused more risk and secondary problems than any benefit in that setting. However, with the emergency neurosurgery, because of the higher bleeding risk associated with the surgery, it makes sense to give them platelets. The effectiveness of desmopressin with or without platelet transfusions to reduce the expansion of hematoma is uncertain, though I do recommend desmopressin if patients are on dual antiplatelets, because we do know these patients do have hematoma expansion and there's really nothing much you can do. And hopefully that desmopressin helps in a little way, but definitely for patients who have platelet dysfunction as a result of renal disease, it is definitely beneficial. For patients with spontaneous hemorrhage who are treated with aspirin and who are not scheduled for emergency surgery, platelet transfusions are potentially harmful and should not be administered. Moving on to vascular imaging, because every time we see a patient with an intracerebral hemorrhage, we are not always certain why the hemorrhage occurred. So should we be doing vascular imaging? And if so, is there a particular patient population that should be getting vascular imaging? And so the updated guidelines say that anyone less than 70 years without typical hypertension-related deep territory intracerebral hemorrhage should get some form of vascular imaging. And if you recollect, I showed you up front what the CTs for patients with those typical hypertensive-related hemorrhages look like. CTA or CT angiogram and MR angiogram have greater than 90% sensitivity and specificity after hemorrhage for the detection of intracranial vascular malformations, but it's only in a highly selected population. And that is comparing it to the gold standard, which is the digital subtraction angiography, because the angiography has the highest diagnostic yield, but it should be used as an adjunct to getting some sort of CT or MRA imaging methodology, or if you're unable to get it and you are highly concerned that the patient is not presenting with a history of hypertension or a hypertensive location for a hemorrhage, actually the 2020 guidelines have gone on to add that you should also be looking for signs of small vessel disease on imaging, which is white matter disease, that you can even see on CT, not necessarily you need to look for it in MRI. So if none of these findings are there, then you really should consider that patients should be getting an angiography to ensure that there isn't a vascular etiology for the hemorrhage. It should also be done if you see evidence of macrovascular lesion, either on the CT or the MRI, and for all patients that present with a primary intraventricular hemorrhage, because patients who present with intraventricular hemorrhage alone have a 20% chance that they have a macrovascular lesion, like an AVM or an aneurysm that led to that hemorrhage. In patients with a lobar hemorrhage and who are less than 70 years of age,
Buenos días, Andrea.
Have a deep or posterior fossa hemorrhage and are less than 45 years of age, the diagnostic yield for macrovascular cause is about 17%. So for the younger age, location of hemorrhage, absence of signs of small vessel disease, and a positive or inconclusive CTA, these are all independent predictors for the presence of an underlying macrovascular cause. So if you are highly suspicious because they don't fit in to all of the criteria as described, then you should consider an angiography for them. Now, the 2022 guidelines also brought in venography, which has actually not been mentioned in the previous guidelines. And if there is concern that it could be a venous thrombosis-related hemorrhage, then you should do either a CT or MR venography. And this should be based on the risk factors, the clinical factors. If it's a young person, if they are on pregnancy preventing medications, and or they have underlying other additional risk factors that could potentially cause them to have a cerebral vein thrombosis, and the location of the hemorrhage suggests that it possibly could be that, then you should get venous imaging. When do you do neuromonitoring, including monitoring of ICP, and when do you initiate edema treatment? Because we know that all patients that present with an intracerebral hemorrhage will develop some form of cerebral edema. I think it is pretty intuitive that anyone who has hydrocephalus should get an external ventricular drain, because it has a clear association with reduced mortality. If patients present with moderate to severe intracerebral hemorrhage or intraventricular hemorrhage with a reduced level of consciousness, that defined as an GCS of less than 8, because that's what the Trauma Foundation guidelines state, then you should consider ICP monitoring in those patients. We do know that early prophylactic hyperosmolar therapy, which includes mannitol or hypertonic saline, either it be 2%, 3%, 7%, or 23.4%, there is not been established improved outcomes as a result of having done that. However, if they have an elevated ICP as measured by your invasive monitoring, then you can consider bolus hyperosmolar therapy, and it doesn't matter which one you use, but you want to reduce the ICP. There is absolutely no role for corticosteroids in patients presenting with intracerebral hemorrhage for the edema treatment. So corticosteroids should never be used in these patients hyperacutely. Now, with regards to surgical intervention, the guidelines have essentially switched to stating that if you're going to operate on a patient with intracerebral hemorrhage, then really you ought to be considering minimally invasive surgery. Again, it is easy to state minimally invasive surgery as the treatment option for patients who are presenting with greater than 20 to 30 ml volume that have a lower GCS score, but we do acknowledge and recognize the fact that not every neurosurgeon performs minimally invasive surgery. It does ask for a higher level of imaging, maybe even imaging guided placement of catheters, so that you can either endoscopically remove the hemorrhage and or use thrombolysis and remove the hemorrhage. And these guidelines are based out of the MISTY 3 trial that showed that outcomes were better for patients who had minimally invasive surgery. Now, who do you consider for a craniotomy? So for most patients with spontaneous supratentorial hemorrhage of moderate or greater severity, the usefulness of craniotomy for hemorrhage evacuation to improve functional outcomes or mortality is uncertain. But if the patients are deteriorating, you can do craniotomy with or without hematoma evacuation because it is considered as a life-saving measure. It does not improve their functional outcome other than the fact that death can be prevented in these patients. The only indication for surgery is for cerebellar hemorrhage. The previous guidelines stated that if you had a cerebellar hemorrhage that measured more than 3 centimeters, then that is somebody you should consider for hematoma evacuation. These guidelines have updated it and have become a little bit more specific for patients who have cerebellar hemorrhage, who are deteriorating neurologically, have brainstem compression and or hydrocephalus because of ventricular obstruction, or have a cerebral hemorrhage with a volume greater than 15 ml, immediate surgical removal of the hemorrhage with or without an external ventricular drain placement is recommended and is actually preferred to medical management to reduce mortality. Now, such a strong indication for cerebellar hemorrhage is based on the fact that patients who have cerebellar hemorrhages actually can, if they are evacuated, can come out of this with very little in the way of symptoms and can go on to have pretty normal lives. So in this case, it makes sense to evacuate this, especially if they're deteriorating. And these are the surgical management for intraventricular hemorrhage, and these are based on the CLEAR 3 guidelines that you can consider an external ventricular drain with thrombolytic use because it can reduce mortality and improve functional outcome. Though the benefit is not very strong, it is definitely something that has to be considered. So I will summarize the talk just because there's a lot of information that has been given. We know that we must reverse coagulopathy as quickly as possible. PCC is superior to FFP, and if you don't have the specific reversal agents, then please consider PCC for the reversal of DOACs. For patients that present with elevated blood pressure, if they have a small hemorrhage defined as less than 30 cc's, then you must lower their blood pressure across the board, but for sure, you can consider lowering it to less than 140 for patients who present with large hemorrhages. If you have an ICP monitor, target a CPP greater than 60. If you don't have an ICP monitor, perhaps we're still okay maintaining it less than 160. With regards to surgery, there's only very, very select patients that meet criteria for surgery. But for sure, patients who have greater than 15 ml cerebellar hemorrhage, they should be undergoing surgical evacuation. Thank you very much.